right. Thank you very much. If I can start the slideshow. Okay, so thanks everyone for being here. My name is Brian Eckerly. I'm one of the stroke neurologists. I appreciate the introduction, Dr. Cooper. And we'll just get right into it. I don't have any disclosures. My talk is about stroke mimics and also stroke chameleons. So just to start with some definitions, what are stroke mimics and chameleons? A stroke mimic basically is something that initially looks a lot like an acute ischemic stroke, but the final diagnosis ends up being something else. And stroke chameleons are sort of the opposite. These are the ones that give us heartburn, cost us sleep, and make us anxious. These are patients who present with presentations that aren't classically consistent with stroke, but that end up having a final diagnosis of acute stroke. And they're both important, and we'll talk about why. So stroke mimic, again, a neurological presentation that looks a lot like a stroke, but is not. These things are exceedingly common. We see this almost daily on the stroke service. It has particularly important impacts on decision-making around IV TPA, and then also our ability to deliver care in a cost-effective and sound way for our patients, and ultimately improve outcomes, which is our goal. To take one small step back and talk about the definition of acute stroke, if you've been on rounds with me or near me in the hospital or in a conference with me, or heard one of these talks, you've probably heard me talk about how stroke is a clinical definition, a clinical diagnosis, and it means the sudden onset of focal symptoms referable to a specific area of brain. Stroke is not a radiographic definition. It's not dependent on an MRI result. It's not even dependent on getting an MRI. To make the diagnosis correctly, you need to understand neuroanatomy, neurovascular anatomy. And then, like anything in neurology, there are caveats. Nothing's 100% true or false ever. Though we typically say strokes are ictal in onset or most severe at onset, that's not always true. And then there are the occasional patients who have multiple strokes simultaneously that can present with a constellation of symptoms that can be a little confusing because they're not referable to a single territory, because there's more than one infarct going on. So just to go over some of the mimics we're going to talk about, most common that we see, those include seizure, migraine, metabolic encephalopathy, brain tumors, more metabolic encephalopathy, and then functional disorders. So let's start with seizure. Seizure can mimic stroke both during the seizure and after the seizure. So most classically, we see folks with the so-called Todd's paralysis, where they've had a seizure, the seizure is over, and the area of brain from which the seizure emanated is temporarily not functional. And so we see symptoms that look sudden and look referable to a specific area and look a lot like a stroke, but wind up having been a result of a prior seizure. So some things in the history that make me think about seizure as a possibility, if the onset of symptoms is unwitnessed, because specifically here what we're thinking about is the possibility someone may have had a seizure in their bedroom or hospital room or wherever, and no one saw them, and then they found them later, now post-ictal. That makes us think a little bit about seizure. If they have epilepsy and have had seizures in the past, that would make me think about seizure. If they have any what I call positive symptomatology, so typically stroke presents with negative symptomatology, meaning loss of function, so weakness or loss of sensation or loss of coordination, loss of vision. Seizure, on the other hand, tends to present with positive symptomatology, so excess movements, that's the tonic-clonic jerking of a seizure, or even positive sensory symptoms or positive visual symptoms. Those more likely represent seizures rather than stroke. If they've had recurrent presentation, so if this is the fourth time they've shown up in the emergency department with this exact same symptom sort of story, that makes us think about seizure. And then people who are quickly getting better. And that's certainly not exclusive to seizure, but as the patient is clearing the Todd's paralysis, things will get better over the course of minutes to hours. And that would raise the possibility of a seizure too. So how do we tell these apart? Mostly with MRI and EEG, but also with clinical examination. So specifically with respect to eye movements, this is a question I ask a lot about on acute stroke call when we're seeing patients and trying to make this distinction between stroke and seizure. This diagram over here on the right side of the slide, I'm not going to go into in painful detail, but basically our eye movements, our voluntary horizontal eye movements, are controlled by a part of the brain called the frontal eye field, and there's a right and left frontal eye field. The frontal eye fields are tonically active, meaning they're always active at some low level, and in the normal person, they're equally active, and so they sort of cancel each other out. The right frontal eye field is responsible for movement of both eyes to the left, and the left frontal eye field is responsible for movement of both eyes to the right. And so when, again, if you've not had a stroke or a seizure, both frontal eye fields are tonically equally active. They sort of push against each other, so to speak, and the eyes are in the midline. When someone's had a stroke that affects, let's say, the right frontal eye field, we now have a right frontal eye field that is no longer tonically active because that brain is dying, and we have an unopposed left frontal eye field. So the left frontal eye field continues to be tonically active, even though the person is not trying to look to the right. But because that tonic activity is no longer being canceled by the right frontal eye field, the eyes will move to the right. And so that's the axiom, is that patients look towards the side of the stroke. So if the stroke is on the right side of the brain, the eyes will look to the right because of unopposed left frontal eye field activity. The opposite is going to be true for a seizure. So in the setting of a seizure, if we're having a left hemispheric seizure, for example, the right frontal eye field is still tonically active at a low level, but now the left frontal eye field is more active because it's having extra activity and extra discharges, and is going to sort of override and trump the low level tonic activity of the right frontal eye field. So a left hemispheric seizure will result in excessive activity of the left frontal eye field and movement of eyes to the right. So that's the so-called eyes moving away from the right side. Eyes moving away from the seizure. So that's where that comes from. The eyes move towards the side of a stroke and away from the side of the seizure. So if you're seeing a patient who has right-sided weakness and aphasia, and their eyes are to the left, that would be suggestive of a left hemispheric stroke. If they have right-sided dysfunction and their eyes are also to the right, that would raise the possibility of either a seizure or a brainstem stroke or another sort of false localizer. So that's part of the sort of diagnostic assessment we're doing in these folks to make this distinction. As far as MRI goes, generally speaking, right, strokes cause diffusion restriction on MRI, and in epilepsy patients, we're looking for things specifically that enhance, although non-enhancing things can cause seizures too. But the point here is that not everything that causes restricted diffusion is a stroke, and not everything that causes contrast enhancement is a seizure. So what we have on the left side here is a DWI MRI showing some restricted diffusion after a patient has had a seizure. And the clues here are that the restricted diffusion only really affects the gray matter. So you see it mostly in the cortex and in the head of the caudate up here, and it's not really affecting the white matter. And then it's in multiple territories. So for this to be a stroke, you'd have to invoke 4 different sort of events happening simultaneously. And so this can be confused for a stroke, but this is actually post-ictal restricted diffusion. And on the other side, we have sort of the inverse of that. This is a patient who's had a right PCA stroke remotely, and we know that stroke in the subacute phase, sort of week to 2 weeks or so, and sometimes longer, can have contrast enhancement. And so the MRI, while very helpful in making these distinctions and a huge part of what we do, is not the final answer in sort of making these diagnoses. Another interesting sort of cool thing about imaging here with respect to seizure. So CT perfusion is something we've started doing a lot more in acute stroke. This shows us sort of how quickly blood is moving through the brain. It helps us mostly with making decisions about mechanical thrombectomy, but it can give us some clues to other diagnoses also. And so what we're seeing here is a patient on the left side who has left hemispheric symptoms and a left hemispheric stroke. And so what we're looking at are maps of cerebral blood volume, time to peak, which is how long until the contrast moving through the capillaries reaches its maximal intensity, cerebral blood flow, which is analogous to time to peak, mean transit time, which is also analogous to time to peak, basically just showing us how quickly blood moves through the brain. And so what we see here is that the time to peak is, there's a little tiny legend up here.
What? Glad I wasn't picking my nose or anything. All right. All of the things that could go wrong have went wrong today. That's what we're good at, adapting and overcome, right? Ooh.
Announcement for any of you vegetable type people. There's a type class 1 broccoli recall.
I'm glad I didn't buy
Bravo
broccoli.
Fresh out of Salinas, California, that was sold at Walmart around Arkansas, Arizona, California, Colorado, Illinois, Indiana, Louisiana, Michigan, Montana, Nevada,
The
Oklahoma,
diagnosis of stroke.
Utah, Washington.
So how far were we in?
Stop researching with ChatGPT.
To the end. Yeah. Sure we
The
are.
diagnosis of stroke.
It's their market fresh broccoli flower eggs.
Oh, bummer. There's some pretty pictures at. That's where we were at. That's all words, 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 words. Papa. Yeah. Maybe right in there. Right there.
Another interesting sort of cool thing about imaging here with respect to seizure. So CT perfusion is something we've started doing a lot more in acute stroke. This shows us sort of how quickly blood is moving through the brain. It helps us mostly with making decisions about mechanical thrombectomy, but it can give us some clues to other diagnoses also. And so what we're seeing here is a patient on the left side who has left hemispheric symptoms and a left hemispheric stroke. And so what we're looking at are maps of cerebral blood volume, time to peak, which is how long until the contrast moving through the capillaries reaches its maximal intensity, cerebral blood flow, which is analogous to time to peak, mean transit time, which is also analogous to time to peak, basically just showing us how quickly blood moves through the brain. And so what we see here is that the time to peak is, there's a little tiny legend up here, but this is high, this is a long time, and this is a low time. So the brighter the color, the longer this blood's taking. So this blood flow is obviously very sluggish on the left side, and that's because there's a blood clot preventing normal blood flow, which is causing the stroke. So this is a patient with a left hemispheric stroke, aphasia, right-sided weakness, and a CTP that matches that. On the other hand, we have another patient with left hemispheric dysfunction. This is someone who has right-sided weakness and perhaps aphasia, and we see the same map, but in this instance, we see more blood volume in the hemisphere that isn't working correctly, and we see a shorter time to peak. So during a seizure, the brain is actually hyperemic, getting more blood flow. And so the blood is moving through the hemisphere faster. And so if you just looked at this, you saw a patient in the emergency room, they were having aphasia, right-sided weakness. You look at their CTP, aha, there's asymmetry. This is a large vessel occlusion stroke. This person needs to go to the OR. But what we're actually seeing here is the opposite. The blood flow is excessive in the hemisphere that's dysfunctional. And that is a finding that we see in seizure rather than stroke. A few words about seizure chameleons. So it is possible for an acute stroke to present with a seizure. Anytime someone is having their first ever seizure, it's at least theoretically a concern that might have been provoked by an acute stroke. We sometimes can see that on a CT angiogram, for example, a cortical branch occlusion, where we see both a stroke and a seizure sort of simultaneously. Some epidemiologic data suggests that 3% or so of all patients with acute ischemic stroke have a seizure during their hospitalization. That's more common in people with hemorrhagic stroke, but we do see it in ischemic stroke too. So just having a seizure in a vacuum is not enough to say there's also not a stroke necessarily. Moving on to migraine, another stroke mimic. So this is a pretty common one. The aura of the migraine can mimic a stroke. It causes negative symptomatology. And we think about migraine in young people, people who have a history of migraine, obviously, people whose symptoms are followed by headache, and then the so-called marching onset. So migraine occurs with this, what's called cortical spreading depression, where the migraine focus starts small in the brain and then sort of progresses outward in a marching fashion. So people with classic migraine aura have sort of a progressive onset of their focal neurologic symptoms as this cortical spreading depression is taking place. That's in contrast to stroke, which again is typically sort of all at once that it occurs. So if you have a young patient with marching onset of symptoms, they now have a migrainous throbbing headache, this is much more likely to represent migraine than stroke. Some chameleons around migraine that you have to be aware of. Just a headache in and of itself is obviously not exclusive of stroke. Carotid dissection, vertebral dissection can present with headaches that look very migrainous. They can be throbbing, light sensitive, etc. Reversible cerebral vasoconstriction syndrome, PRESS, and venous sinus thrombosis all cause headache with sudden focal neurologic symptoms, and they represent worrisome problems that need to be evaluated and shouldn't just be written off as migraine. The other thing is that young patients who don't have risk factors can still have occult cardiac disease. And in fact, in patients under age 50, under age 40, the most likely cause of acute stroke in those folks is occult cardiac disease. And so just being young and not having risk factors is not definitive. It's just more suggestive of migraine. Lots of stroke patients complain of headache, as 44% of people. It's more common in posterior circulation stroke. So this is, again, there's no single piece of the history or exam that definitively makes this diagnosis. Again, the diagnostic tool here, MRI with diffusion with the same caveats. MRI is not perfect, but it's pretty good at picking up stroke and helping us differentiate. Another mimic, this one's pretty straightforward, hypoglycemia. Both hypo and severe hyperglycemia can cause focal neurologic symptoms that look identical to stroke. Hypoglycemic patients can also have autonomic dysfunction. They can be kind of agitated and confused. This one's pretty straightforward because one of the first tests they should get when they arrive in the hospital is a finger stick. And if their sugar is 15 and they have focal neurologic symptoms, we just recommend giving them glucose. Brain tumors. So we see this not uncommonly also. Glioma, lymphoma, encephalomyelitis. These can present both clinically and radiographically sort of similar to stroke, and we'll look at some pictures. The difference here is that mast lesions cause vasogenic edema, strokes cause cytotoxic edema, and those have some different characteristics that we'll look at. Brain tumors don't respect vascular territories, and by that I mean in a stroke, an MCA stroke, you're only going to see involvement in the part of the brain subserved by the middle cerebral artery, whereas in a brain tumor, you'll see involvement of both the MCA and PCA, or MCA and ACA, or crossing the midline, or doing something else that strokes typically don't do. The sudden onset of symptoms in glioma and brain tumor patients are due to one of a variety of things. Either they've had a seizure and postictal weakness, or they've bled, or they have worsening swelling. Here are some images that kind of show what I'm talking about. This hypodensity on the head CT here just is not as confluent as what you would expect in a stroke. You would think with a stroke you'd have a whole wedge of tissue that would be out. What you see here is edema that's respecting the gray-white junction, and here on MRI we see indeed that this is actually a tumor. Here are some more pictures. This is tumor with vasogenic edema that just is sort of heterogeneous. It doesn't have crisp margins. Here specifically respecting the cortical border, versus stroke here, which is really a more confluent, homogeneous wedge of tissue that's affected.
Homogeneous.
Acute coma or acute altered mental status is another very tricky one. There are a variety of things that can cause this that aren't stroke. And in fact, stroke is near the bottom of the list in terms of statistical likelihood of this diagnosis representing acute ischemic stroke. We see this a lot in the hospital in people who have had surgery, who are getting pain medicines, who may be getting unusual doses of insulin, and who are at high risk of thrombotic problems. And so we think about this a little bit when someone's acutely altered, but their blood pressure is low, or they're febrile, or they're doing something else that makes it look like perhaps they're just medically ill. Stroke patients tend to be more likely to be hypertensive. Fever in the setting of stroke should make you pause. And then on the other side of things, hospitalized patients are there with problems that also increase risk of stroke. So heart disease, surgery, blood clots, infections, all of these things increase risk of stroke. And so this is a very tricky one to sort out. The exam is really super important in these people. checking brainstem reflexes, checking eye positions, looking for anything that's asymmetric. So a disconjugate gaze where the eyes aren't looking in the same direction, anything that's more present on one side than the other, any kind of upgoing toe, those things should all prompt us to do more imaging evaluation. These people need to be assessed pretty quickly for the possibility that they could be having a devastating stroke. They usually aren't, but that's something that needs to be excluded. A lot of times we don't have the ability to give them TPA because they've had surgery or they're on blood thinners or they've had bleeding problems or whatever all else. And so they in particular need vessel imaging to make sure we're not seeing a basilar occlusion or some other horrific large vessel occlusive problem. The chameleons for this one, these are the ones that are really, really difficult and devastating. Top of the basilar occlusion, so a blood clot sitting right at the basilar apex where the thalamic blood supply artery of Percheron, which we'll talk about, ACA stroke, venous thrombosis, all things that can cause acute from a vascular cause. So this is top of the basilar and artery of Percheron. So the top of the basilar is just represented here. What comes off the top of the basilar that's super important are these thalamic perforators. So if you infarct both of your medial thalami at the same time, you will get acute coma. And you can get that if you have a blood clot sitting right here, picking off these perforators. You can also get it if you have this anatomical variant called the artery of Percheron, which is the same blood vessels all coming off of one common trunk. So you can have even a small blood clot come up here, get into the artery of Percheron, and include all of these perforators and give you simultaneous medial thalamic stroke and coma. I have a patient on service right now who has this exact problem. Here's some imaging just showing a hyperdense top of the basilar on the non-con head CT, poor filling at the top of the basilar on the CTA, et cetera. And then this is the MRI that you get where you have medial thalamic involvement and midbrain involvement from losing both thalamic and midbrain perforators. ACA territory strokes can cause not really acute coma. These patients are awake, but they can be acutely less participatory with examiner. So people, the motivation center of the brain lives in the medial frontal lobe, which is supplied by the ACA. And so particularly in bilateral ACA stroke, but also in left more than right ACA stroke, you can see people who are awake and they appear to be looking at you and hearing what you're saying, but they just don't do anything. And it's a sudden change. And this can be from abulia or akinetic mutism from a medial frontal lobe infarct in the ACA territory. Venous sinus thrombosis also causes bilateral thalamic involvement. That's because the deep gray, the thalami, the brainstem are drained by the deep, by the cerebral veins that live in the deep venous system. If these are occluded, our venous outflow is impaired and we can have stroke from this. Also, we had a patient on service with this earlier this week too. You should think about venous sinus thrombosis in people who have blood clotting problems, pregnant patients, or recently postpartum patients, and anyone with a sudden headache with altered mental status. The most common thing we see in terms of stroke mimic is functional disorder. So this is also called conversion or somatoform or somatization or non-organic or non-neurologic. This is people who present with neurologic symptoms that are a manifestation of some psychological stressor and are not actually related to any focal brain dysfunction. This is the most common thing we see among these mimics. You can consider this in the setting of recent stressors or similar prior presentations. We had this one this week on service also, but really anyone, anywhere, anytime can present with functional neurologic symptoms. You make this diagnosis with MRI, but also with adept clinical examination techniques. Symptoms that are suggestive of non-neurologic problems are stuttering speech or loss of speech with preserved texting in particular. So people who can't talk but can write their answers to questions or can text questions, that is usually not from a neurologic problem. Weakness of the arm and leg without facial weakness or weakness that involves the upper face and the lower face, or loss of vision in the same eye as the limbs that are weak. Those things all don't localize well to a vascular territory, and so they typically don't represent stroke, although, again, that's not a hard and fast rule. There are some examination techniques that we do that have a variety of sensitivities and specificities. Giveaway weakness is when you ask someone to oppose you in motor testing and they just let go as you start to oppose them. Drift without pronation, if I can demonstrate this, is holding the arms up and then the arm comes down while it remains supinated. That's not usually neurologic. People with actual weakness, the arm should come down and pronate at the same time. That's why it's called pronate or drift. Hoover sign, I may not have time to go into depth about this examination finding, but essentially if a patient is trying to flex their hip, in other words, lift their leg up off the bed, the opposite leg should be extending at the same time. It is almost impossible to try to flex your left hip without extending your right hip. And so if someone is presenting with left leg weakness and their right leg hip extension is normal, but if you hold your hand under their right heel and ask them to lift their left leg and you don't feel any pressure, they're not actually trying to lift that left leg. And so that's what's called a positive Hoover sign. The abductor sign is similar. It basically is, again, a test of the legs where you ask someone to bring their thighs together. It's very hard to intentionally only abduct one side without the other. And so people with actual weakness can abduct their strong leg and not their weak leg, but people without weakness will be weak in abduction on both sides during that test. Midline sensory splitting is not a great one because thalamic strokes very typically cause midline sensory loss. Vibratory splitting is when you take a tuning fork, let's say they're complaining of right-sided numbness, they feel the tuning fork vibrating on their left forehead, but then not on their right forehead. So the frontal bone is continuous. So there's no way if you have intact vibratory sense on the left forehead, you could not have intact vibratory sense on the right forehead. And so that's the vibratory splitting. So those are the mimics quickly. Again, going back to why we care, we spend a lot of money on diagnostic testing for people who don't have stroke. We spend a lot of time spending a lot of money on people who don't have a diagnosis of stroke. And there's at least some risk of symptomatic hemorrhage if we give IV TPA to these folks. So a good, thorough, experienced examiner can make this diagnosis clinically and save time and money and risk, essentially. If we're overly reliant on advanced imaging like CT angiogram, CT perfusion, MRI, we risk delaying IV TPA, which risks increasing morbidity and mortality to people who actually have acute ischemic stroke. And again, being more aware and adept at distinguishing stroke mimics just helps us make these diagnoses more quickly and get people treated appropriately quickly. The chameleons, again, that we talk about a lot, acute dizziness, acute vertigo, can be inner ear disease, but can be stroke. Arm weakness without facial or leg weakness can be from a stroke. We talked about altered consciousness. Sudden onset movement disorder can be from basal ganglia, stroke involvement, and then headache we talked about as well. The chameleons, we care about the mimics, but we really care about the chameleons. These people often cause missed opportunities, or we cause missed opportunities or delays in treatment because stroke's not at the top of the list when they come in. They wind up having a stroke, and by the time we've sorted it out, it is perhaps too late to do anything about it. People with stroke chameleons are shown to get less complete evaluation for etiology. And if they're not getting good evaluation for stroke etiology, they're not getting appropriate treatment. And so they're at higher risk for stroke recurrence. And they just in general do worse. This is epidemiologically described. People with stroke chameleons do worse long-term for those reasons. So the take-home points, mimics are common. They can usually, though perhaps not always, be distinguishable from acute stroke with a good history and exam. MRI is not the be-all, end-all in making this diagnosis. People who are having stroke mimics tend to do reasonably okay with TPA. There's a non-zero risk, but it's certainly lower than the risk of TPA in people with acute stroke. And people with stroke chameleons are going to do worse than classic stroke presentations. So the way I sort of synthesize this and put this together, if I'm seeing a patient in the emergency department who is maybe having an acute stroke, if they have a disabling deficit, if they don't have a contraindication to TPA, and I am not 100% sure they're having a mimic, then I at least consider treating them. I talk to them about it. I tell them I'm not sure you're having a stroke. If you're not having a stroke, this risk is lower. These are the risks and benefits of TPA, but I can't definitively exclude this. And if someone has a disabling symptom, I treat them. If you're not treating any stroke mimics, my opinion is that you're not giving enough IV TPA, because I think all of us who do this a lot have treated mimics a lot, and that's just sort of part of the game. You'd much rather treat a mimic, put them in the ICU for a day, spend money, and they turn out to be having a migraine or a functional disorder or whatever, than not treat a chameleon and miss the opportunity to help someone having a neurologic emergency. So that's my summary of stroke mimics. Sorry that was a little rushed. We got a little short on time.
7 out of 10 cats prefer Blue Tastefuls chicken to Heinz chicken. Try Blue Tastefuls.
God, don't let God turn tigers.
All right. So, big head. That is our last stroke section. We're going to break for lunch, and we will see everybody back at 1.